Valvular heart disease describes an abnormality or a dysfunction of any of the heart's four valves. That would be the mitral and the aortic, those are the left-sided valves, and the tricuspid and the pulmonic on the right. Valvular heart disease is classified as stenosis, which means narrowing of the opening, and that impedes blood flow from moving forward. And then we can have valvular insufficiency, which is improper closure, and some of the blood flows backwards where we have regurgitation. It can also be congenital or it can be acquired. Congenital heart disease affects all four valves, one of all four or all four at the same time, and it can be either a stenosis or an insufficiency due to a congenital defect. Acquired valvular heart disease is classified as either degenerative disease, and that's due to damage over time from mechanical stress, and the most common cause of degenerative valve disease is hypertension. We can have rheumatic disease, and that's a gradual fibrotic changes, calcification of the valve cusps, and it's most often seen in the mitral valve with rheumatic heart disease. Infective endocarditis is also a culprit, and that's an infectious organism destroys the valves, so they become vegetative. That's a common term that you'll hear. Streptococcal infections are most common cause. That's why we treat strep. We treat strep throat so it doesn't go sit down on a valve and become vegetative. That's why we treat rheumatic fever. We don't want later on in life to have diseased valves. Most often we see the left side valves more commonly affected because of the higher pressures on the left side of the heart. And as individuals age, fibrotic thickening occurs in the mitral and the aortic valve. And the aortic valve is stiffer in older adults because we have that increasing systolic blood pressure and stress on the mitral valve. So to promote and prevent, we want early detection and prevention of rheumatic fever. We want to treat that. It helps prevent valve disease. We want to encourage all individuals to have a diet low in sodium, and if they have heart failure or valve disease, we're talking about fluid restrictions prescribed by a provider to prevent any type of failure. Okay, risk factors. What are the risk factors for valve disease? Hypertension, rheumatic fever, which can cause mitral stenosis and insufficiency, infective endocarditis, congenital malformations, Marfan syndrome, and that's where a connective tissue disorder that affects the heart and other areas of the body. Most famous Marfan syndrome, Abe Lincoln. Just a little bit of trivia there for you. In older adult clients, the predominant cause of valvular heart disease is degenerative calcification. We might see papillary muscle dysfunction and infective endocarditis. We'll see that in the older population. A murmur can be heard, and that's from turbulent blood flow, and the location and timing, so is it diastolic versus systolic, will help to determine which valve's involved. Murmurs are graded on a scale from 1 to 6, which 1 is very faint, 6 being extremely loud. As nurses, we're not going to be doing any grading, but we need to know what a murmur is, and it's a whooshing sound, and we can say it was a really loud whooshing sound that we heard wherever. So if you work in cardiology, you'll become better at it. The more you hear, the better you are at it. So let's look at our subjective and objective data that we're going to get from these individuals. So with left-sided damage, we're going to see dyspnea, fatigue, increased pulmonary artery pressure if we had a Swan-Ganz catheter in there, and then we had decreased cardiac output. So if we see left-sided valve disease, this is what we're going to see. With mitral valve stenosis, we'll see palpitations. They may have hemoptysis, hoarseness, dysphagia, jugular vein distension, orthopnea, cough, There will be a diastolic murmur, and we could see a rhythm of atrial fibrillation. If they have mitral valve insufficiency, we'll see paroxysmal nocturnal dyspnea, so they sit up at night because they can't breathe, orthopnea, palpitations. There might be an S3 or an S4 heart sounds, crackles in the lungs, possible diminished lung sounds, systolic murmur, and quite probably atrial fibrillation. With aortic stenosis, angina, syncope, decreased systemic vascular resistance. They may have an S3 and an S4. There may be a systolic murmur, and they will have a narrowed, or could have a narrowed pulse pressure. And with aortic insufficiency, angina, you notice with those aortic valves, they have the angina because the coronary arteries are fed right by that aortic valve in the coronary sinus there. So there could be an S3 heart sound, there could be a diastolic murmur, and widened pulse pressure. So that's the kind of thing we're going to see on the left side. Now with the right-sided valves, we're going to see dyspnea, fatigued, increased right arterial pressure, peripheral edema, jugular vein distension, and hepatomegaly. Kind of like right-sided heart failure, isn't it? It's backing up into the periphery. Left-sided lungs, right-sided periphery. So tricuspid stenosis, we're going to see atrial dysrhythmias, diastolic murmur, and decreased cardiac output. With tricuspid insufficiency, there will be delays in the conduction system, so we're going to see changes in the EKG. There could be supraventricular tachycardia and a systolic murmur. With the pulmonic stenosis, so this is going into the heart, or from the heart into the lungs, cyanosis, systolic murmur, and with insufficiency, we'll hear a diastolic murmur. Okay, so how do we diagnose valve disease? Chest x-ray. It can show chamber enlargement. We can see pulmonary congestion on a chest x-ray, and if there's any calcification around the valves themselves, they'll show up white, correct? Because the denser it is, the whiter it is on an x-ray. So the valves might have little calcifications we'll see on it. A 12-lead EKG will show chamber hypertrophy. Echocardiogram will show the size of the chambers, any hypertrophy, any specific valve dysfunction, because we'll be able to see the flow through there. We'll see ejection fraction and any regurgent flow. So we'll be able to see that on an echo. Echoes are great diagnostic tools. They tell us so much and being not as invasive as some of the other things that we do. Exercise tolerance test, which is a stress echo. It's used to assess the impact of the valve problem during stress or cardiac functioning, so that can be done either on a treadmill or prostatin-induced or medication-induced. Radionuclide tests, it determines the ejection fraction during activity and rest, and then angiography, it's a cardiac catheterization. We go in and we look at the chamber pressures, ejection fraction, regurgitation, pressure gradients, and typically if they're in doing that, they're going to shoot the coronary arteries too, because they're in there already, so they're going to have a look. So our nursing care, we're going to do weights, daily weights, note any changes. We're going to assess their rhythm. It can be irregular or bradycardic. We're going to listen for murmurs. Oxygen, medication as prescribed. If we have a Swan-Ganz catheter in place, we're going to be doing hemodynamic monitoring. Maintain fluids and sodium restrictions, and we're going to stage our care so we can conserve energy for our patients. Typical medications we see are diuretics to use to decrease preload. We're going to use afterload reducing agents to help that heart pump more easily by altering the resistance to contraction. Those are the ACE inhibitors, beta blockers, calcium channel blockers. We may be using inotropes such as digoxin, maybe dobutamine, dopamine. That helps us increase contractility and improve the cardiac output. Patient may be on anticoagulants. If they have a mechanical valve replacement, atrial fibrillation, or severe left ventricular dysfunction, we'll have them on anticoagulation. Who's involved? Everybody's involved with these guys too. Respiratory for breathing treatments, inhalers, airway management. Cardiology for cardiac management, all those diagnostic methodologies that we're using. Nutritional services, help with weight loss or weight gain. Any kind of food drug interactions, special diets. And then rehab services definitely should be consulted if we have a patient that has prolonged weakness, and assistance to help them increase their activity level. So what do we do to help these people? Well, we can do a percutaneous balloon valvuloplasty, and how the procedure can open aortic or mitral valves that are stenotic, and there's a catheter. It's done in the cath lab. It's inserted through the femoral artery, just like a cardiac cath, advanced into the heart, and then the balloon is inflated in the stenosis, and it helps open and improve the leaflet mobility of the valve. I always hope these work, because wouldn't that be so cool just to fix your valve problem, your stenotic valve, just by a valvuloplasty? Sometimes they do, because you're still using them. They work. They could have surgery to treat the valve disorder. They could do a valve repair. They could do chordae tendineae reconstruction, so if they have a valve that's flapping from a ruptured chordae tendineae. Commissurotomy, which is relieves stenosis on the leaflets. They could just put a ring in there, an annuloplasty ring. Maybe it just needs to have stability of the ring. And then they could have a prosthetic valve replacement. They can be either mechanical or tissue. Mechanical valves last longer, but they do require anticoagulation following. A human tissue valve, which is a cadaver valve, that lasts about 10 to 15 years. Medical management is appropriate for many older adults, because surgery will just put them over the edge and interfere with their daily activities, and they won't be able to get back up to where they started. So the goal for surgery for older adults is to improve quality of life rather than prolong it. So if they're not going to be improved by it, they may not do a valve replacement. Post-surgical care of these patients for the nurse is just like a bypass surgery patient. We're going to care for that sternal incision. We're going to limit activity for 6 weeks. We'll monitor for fever. 3 days post-operatively, they always have, no, they don't always, but many go into a dysrhythmia, typically atrial fibrillation. So after discharge, we want to talk to them about any weight loss or weight gain related to medications or their diagnosis, if they need to go into a rehab, if they have prolonged weakness, to increase their activity level. An important post-operative education that your patient needs to understand is prophylactic antibiotics are recommended prior to dental work, surgery, and any type of invasive procedure. They need to go on prophylactic antibiotics. We want to encourage the patient to follow a prescribed exercise program. They need to adhere to any dietary restrictions, and we might get them hooked up with some dietary or nutritional consultation, and teach them how to conserve their energy. Complications of valvular disease is heart failure, which we know is the inability of the heart to maintain adequate circulation to meet the tissue needs for oxygen and nutrients, and ineffective valves will result in heart failure. So then we will move into heart failure treatment. The classification from 1 to 4 is placed upon the patient, and then we'll treat their heart failure. Often a patient will be getting a new valve to improve the failure that they have, and then it will improve their quality of life.